Hello, I'm Nurse Linda, and welcome to the Ask Nurse Linda webinar. I'm here with Kelly, who's running the technology, and Zach, who's answering questions in the web chat. You don't see them, but they're here. It's like the Queen of England used to say, when I walk around, everything looks like a swan on the water, but you don't see how fast the swan's feet are pedaling underneath the water. So Kelly and Zach are the ones who are supporting us today to make everything go well and look good. So thank you very much for that. You'll see the ALS interpreter is here. So thank you for that as well. I will describe myself. I'm a lightly pigmented skinned woman with brown hair on video. It has a lot of gray in it otherwise. I wear pink framed glasses and I have on a white sweatshirt today that's got some lace on the top. So, super fancy. Also, where I live, we've been under the heat dome for I don't know how long now, and it's broken. So it feels cold, although it's very pleasant outside. But it's caused my hair to be very frizzy. So my hair is shoulder length, but it's very frizzy today. So that is what I look like. So welcome. There's a lot of things that are going on in the world of neurological recovery and recovery from paralysis. And so people have a lot of questions about these things. So we'll have to get involved in that. But one thing I wanted to point out is remember, you can go to the Reeve Foundation for all kinds of educational information. It is all absolutely free. You can just go online and print it right off your own computer, or you can call or write to the foundation and they'll send you a hard copy if you prefer to get those kinds of things. And then one thing I wanted to highlight was there is a booklet called Emergency Preparedness, and I like to bring it up every once in a while because it's a very popular booklet, and it talks about if there's a flood or if there's a storm or something happens or if you're a victim of crime, different kinds of things to think about. It's a book you want to read and think about, but it's information you hope you never have to use. And so it's one of those wonderful kind of things. It's very good to get just to kind of know, what to do. I know a lot of times in some of the recent floodings that have gone on in the past few years, people have their emergency plan for their home and all that kind of stuff, and they know what to do. But then after their home has been flooded, then where do they go and what's the next step? So, it kind of gives you those little ticklers to think about, oh, okay, if something happens and I have no electricity in my home, but I've got to power up my wheelchair or I have to use my ventilator. How am I going to get emergency help quickly to my home? And the answer to that is be sure and let your emergency services in your neighborhood, who's ever covering your neighborhood, the ambulance service, the electrical people, be sure and call them and tell them that you use a ventilator and you need electrical supply. And then they have a list and that will help them keep track of you so they know where they're going and what they need to do when they get there. So not only are they going to get to you quickly, they're going to be well prepared for when they get there. So those are all kinds of things that are just in that book, just a wealth of information. So anyway, we'll start with the questions. Oh, first of all, there's a question in the chat box. Hello, Milton. So I'm going to say hello to you because that's lovely. So anyway, welcome to everyone. It's always my happy day to be here. Oh, and also I wanted to let you know if you're going to be in Phoenix at the Abilities Expo next week, I think it is. Um, be sure and look for me there because I'm going to be there and I would love to see you. You'll have to check the schedule because I can't remember off the top of my head what time I'm speaking. But if you're going there, I would love to meet you. I love to go to those expos and meet people. So be sure and point yourself out and we'll connect and get together. That'll be a lot of fun. Okay, so somebody is looking for updates regarding OT and SCI. Let's talk about that just for a minute. So in spinal cord injury, a lot of people think, oh, the Reeve Foundation, that's for spinal cord injury. But did you know we have more people who have paralysis from other sources of injury or accident, trauma or accident? that use our services as well. So if you have paralysis from neurological disease, head injury, stroke, we get a lot more questions from people with head injury and stroke actually than with spinal cord injury now. So we're full service for paralysis. So think about that. The other thing I wanted to mention is that we talk a lot about spinal cord injury. We talk a lot about head injury. And that word injury is one of those medical words that is used in common language, but it's not quite the same in common language as it is in medical terms. So when we're talking about head trauma, head injury, spinal cord injury, we're talking about trauma from accidents, from diseases, um, all kinds of things. So it encompasses everything. It's not just from like car accidents and you became paralyzed. It encompasses diseases as well. So that word injury is also is from trauma and from diseases. For a while there, we were trying to make it SCI/D, and you'll still see that, and sometimes the D standing for disease, but mostly injury just encompasses everything so that you know that we're talking about that. And being a person who had a family member for quite a number of years with spinal cord injury from disease, I am particularly sensitive to that. So, just know that we're talking about, doesn't matter what the source is, the treatments are usually the same and they're always individualized for the person. So, what works for you might not work for the next person. Always talk to your healthcare provider before you decide to change anything. Remember, I talk in generality. So, I'm speaking to most often, this is what works. It might not be the right thing for you. So, always check with your healthcare professional. So, what's going on, particularly in OT, are things that are going on just in the spinal cord injury world in general. And I know I have spoken in the past about the progress that we have made so much with spinal cord injury. Now, on the second Wednesday in September at 2 o'clock Central Time, we're having Linda Norse Jones, who's a doctor of physical therapy, and Marco from our spinal cord injury research team talking about different research projects. Sorry, flight of ideas. And so that's going to be very interesting. Now, it's going to focus a lot on spinal cord injury, but if you don't have a spinal cord injury and you have paralysis from something else, you'll still want to tune in because all this research that's being done in spinal cord injury or in the nervous system itself will pertain to other diseases, maybe not today or tomorrow, but like in in the near future. So what helps one diagnostic group helps all diagnostic groups. So it's going to be a really kind of interesting presentation because it's going to talk about the complexity of all the treatments that are going on and how complex the nervous system is, but in an understandable way. So to talk about all the different eh, research and things that are being studied, which will all be puzzled together in the end. But some of the things that are going on right now, one of the big things is there's a couple of companies out there that have released a stimulation device, which is some electrodes that are on a long piece of tape that goes on your back over your skin, and it has a goes to a little control box, and people are using this if you put it higher on the area above your on up by in your neck area. It can give you more hand function and give you a little more function, not the way it was before your paralysis, but at least you have some function, and it will keep improving as time goes on. If you place it lower in your back, you'll get some function with bowel and bladder function, maybe sexual function in males, maybe in females, that's still to be determined, and maybe some leg function to help with movement in the legs. So, this is FDA approved through the Onward company. And there's some other companies that are working on similar devices. There's also the Spinex company that has a device that's approved for children with cerebral palsy. So you see, it's the same device, but different um, interpretations of the device depending on the disease and different approvals. So those two things are out. Now, somebody had written in about when can I get this thing? Where do I go to get this? And it is FDA approved. It is available. It could be available through the United States, and they are in the process of rolling out this product. So you won't have to travel anywhere. You won't have to be in an experimental program. You can talk to your doctor, see if you can get the order. The reason why it's taking some time to roll out across the country is because they have to educate physicians. How do you prescribe this? What does it do? They have to educate other healthcare professionals, the therapists, the nurses who will be operating this machine are helping you get used to this machine. It will not make it the way it was before your injury or before your disease, but it will give you more function. And I have seen it. I've seen people who use this device, and it is phenomenal. Will it work for everyone? I would hope that. But, there's always, like I say, everybody is unique. So everybody's a little different. So it might not be for everyone, but it's a great start. And I look back in history. When I very first started in nursing, there was this Dr. Petrovsky in Cleveland who made this device, and it was attached to a computer, a lot of electrodes, and he had this lovely young woman as who was trying it out for the first time, and they had all these electrodes on her, and she was able to take steps with a walker. Now it was under the control of the computer supplying the electricity to her body, but she could get up, and the big frosting on the cake was she walked down the aisle at her wedding. Oh my gosh, it still brings tears to my eyes. It was so wonderful. Fabulous in the fact that this man actually developed this whole thing, which was really phenomenal. Pardon me, I'm going to have to take a little sip of water. Of course, in my hospital mug. But anyway, so that was really cool. But it wasn't really practical for people to use in everyday life because it was such a big, cumbersome thing. And, but it was a start. And that was years and years ago. And then that evolved into the FES bikes, which we still have today. And the first ones were so huge. And some people had to have their floors reinforced because they were so heavy you had to transfer into them. But that was another huge step forward and great for exercise the lower legs. And then they moved forward into a smaller one that you could just wheel your wheelchair up to the bike, and that's what they have now. And so some people have been able to petition their insurance companies and have been able to get that. And then at that same time, when all that was going on, when the biking was becoming big, at the same time, they were inventing implants to give hand function. That was a little bit trickier. OTs would be very interested in this. That one was a little trickier. It was called the freehand system. And there were some problems with the cost and the marketing. It was surgical procedure, so that it was internal, not the device was external, but it was internal. So there was surgery, so that was a big deal. And then when people would get out into the community, sometimes it wouldn't connect well. They were just, because it was a new thing. And as with all new things, it's always kind of a little tricky at first. And then to find an OT that knew how to do it, these things were, it was all very complicated. And so another company bought that out. It's still out there, but I don't think they're manufacturing it right now, but they still have it and they still have the ideas about it. But that was a very, very helpful thing. And then at the same time, they invented implants for pain control. If you had neuropathic pain, very, very severe, that couldn't be controlled with medication. And so they did that. And then they had an implant for bowel and bladder control that you could program, and that's still available out there. Although now with this tape that goes on the back, this other functional electrical stimulation, you probably are not going to need that. They did spinal cord implants to help get control. But now they're kind of moving away from surgery. It's not going to be gone. It will probably come back in some other form. It's still out there, it's still around, but it's just that less invasive, is always better. Oh, and I don't want to fail to mention the diaphragmatic pacemaker, which is also at the Cleveland Clinic. They have the Cleveland Functional Electrical Stimulation Clinic out there. It's really fabulous. But the diaphragmatic pacer, if you are on mechanical ventilation and you would like to try to be off mechanical ventilation, there's this diaphragmatic pacemaker. It's available everywhere. You can get it anywhere. You would have to call the Cleveland Clinic there and probably your healthcare physician to connect with them. And then they can walk you. They have nurses that answer the line and they can walk you through the full process. We did a professional webinar on this a while back. So if you go to YouTube, all the webinars are on there. You can go on there and find that for that diaphragmatic pacemaker, and insurance covers it. Whatever your insurance pays for these sort of things, you have to go through the process of asking for it, specially, and all that. It can be implanted by any doctor that does chest surgery, pulmonary surgery. Can you imagine? It uses the same procedure that those doctors are educated on for other healthcare issues. So they don't have to go through any special training. If there's some curiosity or complication, um, the doctor that works with us will come to your area and help, or they'll guide them, or, online, or they'll give a tutorial. Anyway, so it works out. So you can get it right in your own backyard, which is really cool. Now, some people get off the ventilator. Some people only get off the ventilator like during the day or maybe for a few hours. It used to be that you had to have a trial for it, but it's worked so well that they don't require a pre-trial. They just put it in now. So anyway, things are going just great in all areas. So for OTs, um, for PTs, for nurses, for MDs, for everybody, everything is moving well in the world of paralysis. All this work, like through my career, to see it come to fruition is kind of like, well, it's always like, well, that'll be coming. Well, this will be coming. Well, it's coming right now, and a lot of it is here. So fabulous. Um, and more to come. I call it the Christopher Reeve effect because this Dr. Linda Norris Jones has this. She did a presentation, and she has uh, a chart that she puts in her presentation, and it shows the amount of research that was done in spinal cord injury, and the chart is kind of like at 3 or 4% all around, and then in 2018, 2019, boom, the research jumps up. The number of articles about research just jumps up to like 60, 70%. Now, most of those, the highest percent, are all done with mobility, trying to help people with mobility. But there's a big increase in things like bowel, bladder, skincare, stuff that we deal with every single day. That's important too. And so it's just phenomenal. So I am titling it the Christopher Reeve effect, but that's not official or anything. But that was at the time of his recovery. And that's when things really took off. People, oh, there's possibility here. And so people became very interested in it. So he changed the mindset. What a man. So quite good. There's another question about the literature showing nerve transplants for C5 injuries. Um, for self-feeding, and they're trying to get some information about this for people getting back to work on computers. And then the political move, any chance in people getting on Medicare before 2 years of disability. And I know I went through that with my family member. because 2 years being on disability when you can't work and you're trying to get help, but you can't get help because you can't, et cetera, et cetera. So I don't know about how if anybody's working on that, but I do know we do have a group that works on those kinds of things with the government, and they are very in tune to what's going on. So right now they're working on some things to get organized for our paralysis resource center to ensure funding for that. So anyway, they're working on a lot of things right now. So there's a lot of things going on. But as for the nerve transplants, a lot of people do that. And there's some transplants of the phrenic nerve. That's a real long nerve that goes from the base of the brain down. It works on the heart, it works on breathing, it works on arm control. It has little branches to all the organs in your body. And so it's a nerve that's very busy. And sometimes they will help move that nerve around or do different things with that nerve. Also, sometimes people will do nerve transfers in the arms for hand function. People have done nerve transfers in the cauda equina. That's where your spinal cord comes out of the vertebrae. That's, the spinal column, and that's where your spinal cord comes out. Those nerves called the cauda equina, the ones that are right out of the spinal cord, those nerves, they're still spinal cord nerves, but they're peripheral nerves, not central nerves. Central nerves are in the brain and in the spinal cord. The rest of the nerves in your body are peripheral nerves. Those are the nerves that can be transferred. The ones in the spinal cord, not yet, but it's on the drawing table like so many things are. But these peripheral nerves can be moved around. So there are physicians and surgeons who will move those nerves around to help with, move a nerve from one spot to another spot to help with bowel and bladder function and all that. Those are not experimental surgeries in the peripheral nerves, although they still are working on improving that. They can get movement, like if somebody has a brachial plexus injury with the nerves up in the shoulder and their arm becomes paralyzed, you can still get movement in your hand when they move nerves around up in here or in the cauda equina or moving, different nerves around in the arms and legs. And so all that's still going on. What they're working on in particular now is to take these nerves from donors. So, like a heart transplant or a liver transplant, you might be able to get a peripheral nerve transplant if you don't have a nerve that can be moved around or if it's not strong enough or different things. So, all of that is on the drawing table and being actively worked on. So that's very cool. But so a nerve transplant for the C5 injury, that could be a real option for this person that's writing in. Another thing would be to look for this Onward company. Spinex is going to be coming out with theirs, I'm sure, and there are other companies, and there's going to be a page that's going to come up over in the chat box there, and you can get to the chat box by going down to the screen, bring your cursor over the bottom, and it comes up box there that says chat. And so if you click on that, you can see the chat box and you can get all this information. So using one of these new electrical devices, which is a tape, another thing I failed to mention on that, and this is really cool, is that if you get one of these things and you use it and then say you're going to turn it off because you're going to go to bed at night, or maybe you're only up to tolerating it for a couple of hours a day, whatever your individual needs are. After you turn off the device, there's what they call an overhang, and you still have movement for it can be different periods of time for different people, but you still have movement even without using the device. So the hope is not reality yet, but the hope is that people who use this device will use it for a while and then won't need it anymore because they've re-educated their nerves. That's still experimental. That's still just a thought in the pie. But anyway, so that would be another thing to think about. There are different devices, durable medical equipment that you can get for feeding, and she had asked about that. And she said she had one approved and she had another thing denied. If you get a nerve, okay, the way insurance works, if something is not in your policy, you can have your physician write a letter of medical necessity. If there's a piece of equipment that would really benefit you. And they have to give all the medical reasons why and your medical history and all this and and the research that's available. So these letters are usually written by a healthcare professional because they know medical language and what to say that will be helpful. So sometimes people would say, it'll make my life so much better. Well, it has to be some medical reason why you need it. So, your nourishment would be improved because you could feed yourself. There's like a certain language to these letters. And so if the first letter that goes in, if that item is not already in your insurance policy, you will receive a letter of denial. At the end of that letter, it will tell you how to appeal. And you keep appealing these and keep appealing these until you finally get a letter that says either we're not going to do it or we're going to approve it. So it's a waiting game and it's a very complicated process, but people who have tenacity and just keep going and going. Now, a lot of people will get the letter of appeal and they won't, oh, it's denied. So I'm not going to do this. And so they don't really read how to appeal. Now, your physician will send the letter to your insurance company. That's step one. The response goes to the person who owns the healthcare policy. So your doctor does not get a response unless the insurance policy has a way that they send him a copy of the letter. The response goes to the owner of the insurance policy. So if it's your spouse, if it's you and you're the owner, it will come to you. But if your spouse, say your spouse has insurance through their work and then they're the owner of the policy and you're just mentioned that you're covered on their policy as a family member, the response will go to your spouse, which I know gets complicated if people are divorced, but their spouse is still on the policy. So you have to know what your situation is and how to handle these kind of things because sometimes people, don't let you know that that letter's been there for whatever reason, or sometimes children, if it's a child, the letter will go to the owner of the policy, who is usually one of the parents or guardians. And so if there's a separation in that uh, dynamic, then one parent might not know that this is going on and might not know how important it is. Because you have to get this letter of denial to your healthcare professional right away, because if you're going to appeal, there's a time limit for doing that. Otherwise, the case is closed. So you want to be able to give the healthcare professional time enough to write the letter, this letter of appeal, so they can get that off again. So as soon as you get the letter of denial, you want to get it right to your healthcare policy and just keep going and going. I know some people who have worked on trying to get a piece of equipment for over 4 years, and eventually they get it. Some people get a denial right away after the first appeal. It just all depends on the situation. There's so many variables. So those are kind of things to do, but keep up with it. Just keep plugging away at it. Um, and so, which company do people use for getting patients back to work via the use of computers? Well, in every state, there's a, a state-run vocational rehabilitation um, that's run by the state. If you're at all interested in going back to work, or if you're just kind of sort of thinking about it, um, go ahead and sign up for it. There's usually a long time wait list to get in there because there's only so many positions to you know that they have to fill. So get your name on the list, even if it's just kind of a twinkle in the back of your head. Get your name on the list because maybe by the time your name comes up, you might be like, yeah, this sounds like a good idea, kind of adjusted. We always tried to get people to sign up for voc rehab when they were in the hospital. And I think if you go to a larger rehabilitation center, they will do that. Sometimes community rehabilitation centers maybe don't have that kind of information or whatnot, but get your name on that as soon as you can because they will do everything that they can. They'll give you classes, they give you opportunities. Do you need a special wheelchair to go to work? They help you get equipment and supplies on the work front. If you can't get out of your house because you don't have a ramp, but you need a ramp to go to work, they will get funding to get the ramp to get you to go to work. And then they work with the people in the workplace, and people at some workplaces are looking for people with disabilities because it helps them on their taxes or something. I don't know what it is, but they're particularly looking. And so they contact the voc rehab. Say, we're looking for somebody who can come to work. So they have real good connections in the community. Now, if there's a place where they find that, you match, your skills match, and you could go back to work at this place, if it's your old job, they'll work with your old job. If it's a new job, they'll work with that to make sure that the restrooms are accessible, to make sure you can get in and out of the building, to make sure you have certain rest times in the day or when you have to catheterize or whatever. They take care of all of this stuff, working with you the whole time. So it's really very nice. And so that's a really good service, and that's what a lot of people do. So that's an issue. Oh, somebody wanted to know if some of these new devices are available in India. I really don't know. I
I
know
can answer
Onward
that
is,
for you.
what did
I
you
can
say,
answer that
Zach?
for you.
Okay. I know that they want to be.
Yeah, there are sites that are doing epidural stimulation and those types of studies. There are hospitals in Delhi that I know of that are doing it. ARC-EX specifically has not been rolled out in India, and they're working on expanding the countries where it is available.
Okay. Okay, so it's going to be. If it's not there now, it's going to be. Now, there's another question. Have you heard about the spinal cord transplant that's scheduled to take place soon in Tel Aviv? I have not heard about that, and I would be very skeptical. Now, I'm sure they're doing something, but what they're transplanting is I'm not sure because as of right now, you can't really transplant a spinal cord. Now, maybe they're talking about transplanting, maybe making a link around the area, or maybe putting some extra nerves in there some way, or if the transplant is a stem cell kind of transplant. I don't know, but it's not it there's not a way to take a spinal cord and put it from one person into another person because of all the nerve connections. There are like thousands of nerves that would have to be connected, and you can't do that inside the central nervous system. So yet. So maybe this is going to be the start of that. So we'll have to investigate and see more about that. I know a lot of people are always interested in stem cell transplants, and so I want to mention that as well. So stem cell transplants were really big in the 90s. It was the hoopla. This was going to be the saving thing. Now they still are diligently working on this, and that could be what this is going to be because in Israel and Tel Aviv, in Israel, they have a huge stem cell transplant program. And so this could be what it is. So there's a lot of things that have been accomplished in that as far as putting the stem cells in the body because again, you have to put a needle to put that into the when you have a spinal cord injury from disease or trauma, you have to put a needle into a hole. There gets to be a hole in the center of the spinal cord where the injury is. So there's actually a hole in there. And so you have to put the stem cells in that hole. Well, then that hole has a scar on the inside surrounding that because that's the way the body heals itself. Just like your skin heals and you get a scar. If you get a bad cut on yourself, you get a scar because your skin has healed. Any other part of your body tries to heal. And so the spinal cord will want to wall off the injury because it doesn't want it to spread. And so it will wall off. So getting the stem cells to grow outside of that hole has been accomplished. Getting the stem cells to grow inside that whole has been accomplished, but there's still a lot of details. It is so complicated. There's still a lot more that needs to be done with that. So I bet that's something about that that's going on there. So, we'll just have to follow along and see what that is. If it's coming out of Israel, usually that is pretty legit. If it's coming from a university out in Israel, you have to remember that there are a lot of places in the world that have had scams that have gone on where people have paid tens and hundreds of thousands of dollars for a cure. And these people would even come to your home and they would show you videos of this person. Oh, look, they're up and walking, and look at they're right back to where they started and they did this. And some people had to travel out of the country, and there were all kinds of really bizarre kinds of things going on, but none of them ever really. So people paid all this money, sometimes their life savings, sometimes their life savings and their family's life savings, and it just did not work out. So we have to make sure that we're dealing with legitimate sources. So here's one that my husband is a T6 complete. He's been experiencing stomach pain when he lays down. He's had two colonoscopies, but that nothing's been there. Sitting relieves some of the discomfort. They were in Chicagoland and they'd like to see a physician that's more paralysis focused. Well, you have the Shirley Ryan Institute in Chicago. And so that's one of the premier institutes around. And so I would go there. A lot of people do not realize that T6. So a lot of people do not realize that um, spasms can be inside the body as well as outside the body. So if your foot spasms or your leg spasms or your arm spasms, well, you can see that and you're thinking, oh, okay, there's spasms going on. The muscles are getting confused in their messaging, so they're tightening up. Muscles want to move, so if they're not being moved either on your own volition or having somebody move the muscles for you, they can become spastic, and those that happens in the cervical and the thoracic area. The part of the spinal cord, the thoracic's where the ribs come out of the bones there, but the spinal cord's inside. In those areas, you can have a lot of spasms. And in the lower area, in the lumbar and sacral areas, if you have a spinal cord injury, then usually there's flaccid and there's no tone in the muscles whatsoever. But what a lot of people don't realize is that spasms can be inside the body as well as outside the body. And so that's why the bowel program is more complicated for the people with the cervical and thoracic level injuries than with the lower level injuries. And so it could be just that. It could be gas. Maybe he's having trouble move because if he's not moving his body, then part of moving gas through the body is through movement of the body. So sometimes taking the legs and doing the stretching exercises and bending and moving every joint in the legs and doing that several times a day, and at T6, he might be able to pick up his legs and move that. There are some things called loops that is uh, uh, it's about an inch piece of, I don't know, it's flat, but it's like a piece of like cording, but it's flat. And there's things called loops, and you can Velcro those to your legs, and they have a loop that goes around the leg, and it has a loop that goes where your hand can then pick up the leg and move those things. So that could be a thing. So think about, like a baby who has colic and you move their legs and that releases some of the gas. So that could be it. So there's a lot of different things, but the Shirley Ryan Institute is right there. And there's some other really fine rehabilitation organizations there in the Chicagoland area. But Shirley Ryan is where I cut my teeth in. Well, it wasn't Shirley Ryan then, it was the Rehab Institute of Chicago, but that's where I cut my teeth. My first nursing job in rehab was like heaven. I loved it there. It was so fabulous, and it still is. Oh, Kimberly says, yes, that's a stem transplant procedure. So that going on in Israel, yes, that is what that is. Okay. Um, she says they have successfully operated on mice that have regained ambulation. Yes, as a matter of fact, when we were doing the stem cell project, when I was working with Christopher Reeve in the early 90s, we were also in our where I was working, we had a lab and we're doing stem cell transplants. And even at that time, rats could walk with a partial weight supported walker. Can you imagine if you've seen those for adults? It's where you stand in a harness and there's a treadmill underneath you, and there's some power devices that go on the legs. So the the device or a therapist can get your legs started and your legs will just automatically go even if you've not had a cell transplant. And a lot of people, Christopher Reeve used partial weight supported walking. Now they just call it weight supported walking. You don't start out with a full body weight. You're in a harness, which maybe you're only moving like 10 pounds till your muscles get used to it. And then you add more and more weight. And then they put them on a track so you could go around a gym instead of just walking on a treadmill. That is a legitimate therapy that's going on right now. And yes, we had a little partial weight supported walker for the rats, a little harness that we put their little abdomens in, their front part, and then a little tiny rat treadmill. Can you imagine this? Anyway, yeah. So the fact they've done that and rats are walking, yeah, that would be totally possible. So we did a trial also with some stem cells, but you have to be careful with that because you could make stem cells in the laboratory. And so then some different companies make stem cells, and so you have to put in nervous tissue stem cells into the spine. So they have to be grown in a certain way because it would be no good and it would be harmful to you if you say put cardiac tissue stem cells into the spine. So you have to put nerve cells in there. So it's all very complicated procedure. They're working on it, and I'm sure that they will have whatever their outcomes are. I'm sure that they'll find more information. It either what they're doing is working, or and they can move forward, or maybe they need to modify it in some way. That's the way research works. So, can I have a seizure caused by autonomic dysreflexia? I've never had seizures in the past. Well, that's a very interesting question um, because this autonomic dysreflexia is such an unusual thing. And we had another question that had written in a question about autonomic dysreflexia and COVID-19. So, autonomic dysreflexia is caused from anything that's disturbing the body lower than the spinal cord injury. The autonomic nervous system controls everything that's automatic in your body. So I blink my eyes, it's automatic. My pupils get bigger and shrink down due to the light source. That's automatic. I breathe is automatic. Now, breathing is a little different because I can also hold my breath, but I don't have to stop and think every minute of the day, breathe in, breathe out, breathe in, breathe out, Linda. It just does it. Your heart is automatic. Your blood pressure control is automatic. Um, Infection control, like if you get something like COVID-19, it's automatic. So I call it the automatic nervous system, the autonomic nervous system. I call it the automatic nervous system. So it's anything, your bowel functioning, your liver functioning, your spleen function, it's all automatic. And so anything autonomic nervous system is anything that's bothering the nervous system, but it can't be interpreted correctly either because of spinal cord injury or because of brain injury or stroke. So a lot of people don't realize that this can happen in brain injury and stroke as well, but it can. And so it's not as common as with spinal cord injury, but it happens. So it's kind of one of those curious kind of things. Now, there are three main causes of autonomic dysreflexia, but anything can cause it. So the number one issue is something's bothering the bladder. That's what causes autonomic dysfunction the most. And so it could be your catheter's clogged, it could be an infection in your bladder, infection, you know. It could be that you're wearing your jeans too tight and it's cramping the bladder. It could be anything. Um, The second high number, the second largest cause is from problems with the bowel. Again, overstimulation of the bowel, a bowel impaction, constipation, diarrhea. So you get it from both ends of that spectrum. An infection in the bowel. Um, again, COVID. Um, just anything that's bothering the bowel. Those cramps from that person was having in their stomach. That could cause it because the brain can't interpret what that message is. And then the third thing is problems with the skin. So it can be from an itch, it can be from a pressure injury, it can be from wearing your clothes too tightly, your shoes too tightly, any kind of thing like that. Now, some people who have higher level of injuries will have autonomic dysreflexia from something going on up higher in their head. So I had one gentleman who contacted me a long time ago, but he was having trouble using his computer because he'd have autonomic dysreflexia whenever he used his computer. And there's something about a group in Sweden was studying this at the time. Now, lots more people study it, but at the time, it was only being studied in Scandinavia. And what they were finding is, the computer has this, I call it a backlight. I'm not a computer person, so to all my computer people, I apologize for my interpretation. But there's like this backlight that comes from the computer, and it varies in intensity. And when I was working, we had an office at one time that was actually in an elevator shaft. They put flooring and ceilings in there and made office in an elevator shaft. It was kind of creepy, but and so whenever the elevator next in the wall just next door, whenever it would go up and down, my computer would go like this. The light would go like that on the computer because of the electrical sources. And that's what they found out what that's what they found out the problem was. And so that computer light does something to your head, and that was causing this man's autonomic dysreflexia. So you have to be very careful. Now, sometimes people have it and nobody even knows why they have it. And sometimes they don't have the symptoms from it. And I wanted to see if I had right here. Well, I happen to have the sepsis wallet card here, but we have this for autonomic dysreflexia too. And I must have taken that card into the other room. And we also have one for deep vein thrombosis. So those are free, and they're these little trifold cards, and they explain what the disease is. You should just give them to all your healthcare professionals if you go to the ER, just so that everybody knows. But there's a new thing that they found out about autonomic dysreflexia is that sometimes people have it and they don't know they have it because they don't have symptoms. And so they maybe be having it in their sleep. So, like maybe they got a crick in their neck, but they're asleep and didn't notice it. But there's no real source because people have been sleeping. So it's hard to say, what happened. Well, I don't know. I was asleep. And so, people don't know. Maybe they had indigestion in their stomach. It can come from anything that just can't be interpreted correctly by the brain. So, we recommend that everybody has a blood pressure cuff and that you just take your blood pressure at random different times to see if you're having this silent AD. Because AD is a cardiovascular, it's caused by the nervous system, but it has cardiovascular results. And so we want to keep people's hearts healthy. We want to keep them healthy. So we want them not to have that. So we want to know when they're having it, why they're having it. If you're having so many episodes, there are people who actually take medication for that. And it's all explained in these cards. And we have uh, pages of information about AD, autonomic dysreflexia. So that is something that is really something to be watching for. Are there any guidelines for how long one needs to be weight bearing per day? That is a big consternation. Um, Nobody's quite sure. This is a T1 parent. She was injured 3 years ago. She has a standing chair, but she finds it very awkward. And yeah, they are. Standing chairs are standing frames, is what I was going to suggest. And people usually stand for at least an hour, but if you can stand longer, you can do it. Some of the standing frames. It's a chair you sit on, and then there's either a pump that you manually pump up, and it slowly takes you from sitting into the standing position. And some of them have a tray on the front, some of them have wheels side of the tray so you can kind of have some mobility while you're doing that. Some wheelchairs have standing as well, too. And the thought is that this helps, it helps with, well, first of all, I think one of the biggest things, it's one of the best positive mental wellness things you can do for yourself. It's always very emotional when people stand for the first time when they haven't stood for a long time. It's emotional for the patient and it's emotional for the families as well. So you kind of have to be prepared for that when you first start using one. And you don't have to stand up the first day. Maybe you haven't stood for a long time, so maybe you just, kind of get to a kind of a low squat and kind of keep working your way up on that. You do have to have a bone density test to check to make sure your bones are strong enough to hold your weight. But there's all kinds of benefits to the standing frame. So, and they are approved by Medicare. So just about anybody can get one. Now, is everybody their private insurance? Does everybody have access to one? That I don't know, but they're approved by a lot of different people. So again, you go to your doctor, ask for the medical necessity letter. So anyway, most people do that kind of thing. So, could AD cause one to test positive on a Cologuard test? I don't think so because they're looking for changes in the cells that are in the stool. So AD shouldn't really affect that. COVID could affect that if there are COVID cells in there. What a lot of people don't realize is that COVID loves to live in the ACE cells of the respiratory tract. We all know that. That's been well defined. But did you know that ACE cells are also in your bowel and bladder? And so this is kind of a funny story, but I have a group that I work with, and it's some older people. And so I said, so now if you have to go to the doctor, try to go to the bathroom before you go. So you don't go into a public bathroom, because this was when COVID was really rampant. This was in those 2 years of that. COVID was just everywhere. And so I said, and if you have to catheterize, you want to think about catheterizing in a public bathroom. So, you want to avoid those kind of things, because usually there's ventilation, but you're in the bathroom. Urine is being splashed into the toilets. Now it's going into the toilet, but the COVID germ can fly anywhere it wants to go. Um, People are passing gas when they're in the bathroom, so they're shooting out COVID bacteria if they have COVID. So be very careful when you're in the bathroom. Well, then the next week we met, and so somebody kind of raised their hand and said, "Oh, I just have to tell you, I'm so sorry, but I went to the doctor and I just couldn't wait. My diuretic took action and I had to go to the bathroom. I had to go in a public bathroom. Do you think I'm okay? I tested and I tested." Well, she was okay. And I said, yes, it's not like you're going to go in the bathroom and die, but you want to be cautious about things. Now it's COVID has settled down a bit. People have gotten injections, which gives you a decreased risk of getting COVID, but it doesn't make you completely immune to COVID. And so that's just something. But anyway, uh, so somebody asked if COVID could cause AD. And I would suspect that if you had that infection in your body, AD is in the autonomic nervous system. Infection is being monitored and controlled in your body by the autonomic nervous system. So it makes sense that the two would, I've not heard of anybody having AD from COVID, but it makes sense that that could happen because anatomically it's all in the same system. So it only makes sense that that would happen. Um, so let's see, there was something else about the COVID that I wanted to say, but I guess it will come to my mind. But anyway, this COVID is still out there. And so, oh, I know what it was. So, people with spinal cord injury, I have not heard facts on people with stroke or head injury, but people with spinal cord injury, when COVID was a big thing, we were scared to death because the autonomic nervous system would not be able to mount resistance to it. And so people wouldn't be able to fight it off. And we were very worried medically that so many people would disproportionately die from COVID because they had a spinal cord injury. Well, as it turned out, when the final tally was done 2 years later, there was a slight bit higher of death in from COVID in those people with spinal cord injury, but not significantly uh, amountable to anything. So it was like 0.04% difference in people. So it was a little higher. And that could just be, the number that just goes to, just everyday, you know, different things happening, so it was not the kind of thing where it was like, oh yeah. And so then people were wondering, well, why didn't that happen? And why it didn't happen was people were not able to mount the response, the critical response that was, when COVID just overflowed in the body, people were not able to mount the immune response from this huge infection of COVID, so they didn't have that response, so they didn't die. So, here's one of these things that, in all of medical knowledge, you would think that this would be a huge problem, and it turned out it wasn't at all. Now, that doesn't mean that, you still shouldn't take precautions because, people did die from it. So these are the kind of things that you just never know how life's going to twist and turn around. So it's kind of one of those weird kind of things. Um, Let's see. Oh, somebody wants to do their bowel program. They've been doing digital stim for 25 years. They don't want to take laxatives. And no, we don't recommend anybody take laxatives for their bowel program because that makes your bowel movement unpredictable. And so it will happen anytime, anywhere, and then you're sitting in it or laying in it. And you don't know it's there until you smell that it's there. And usually in the hospital, patients will say, I think my therapist was really passing gas today. Oh, I smelled this horrible thing. And then you be like, well, no, I'm sorry. You were incontinent. And then they're horribly embarrassed, because they were blaming it on other people because they didn't know. And so it's, this is one of those things. So if you want to add, talk to your physician. People find a lot of luck with suppositories. That's generally the magic bullet or Duplex suppository. There's also something called the mini enema, and that's about a tablespoon of fluid. It's put out by enemies. And sometimes people will use that. And then when you use those suppositories or the mini enema, then you have a certain amount of time and then the stools start coming out. You still have to do the digital stimulation to make sure that bowel is completely emptied. And I know somebody was asking last time we were on about how do you know? And I want to reiterate that you have to do the digital stimulation and feel that the bowel is completely emptied, that the stool is out of the lower bowel. And that's how you know. So sometimes you have to do digital stimulation a couple of times, and you want to be very gentle when you do the digital stimulation. Most people are shocked to learn about a bowel program. I have yet to hear a patient say, oh, I've just been waiting to do this. Nobody has ever even heard of it. And so people want to, they want to get in and they want to get out quickly because it's not something that appeals to people. But when you do the digital stimulation, you want to be very gentle because people want to get in and they want to swirl and they want to get out as quickly as they can. But remember, the quicker you're going, the tighter you're making that inner sphincter because it's going to spasm. And so the more aggressive you are, the tighter it's going to be. So use a lot of lubricant so that you don't give yourself hemorrhoids or tear your bowel tissue because your bowel's not waiting for something to be entered into it. It's only there to remove stool. So be very gentle with yourself because you want to relax that inner sphincter. And that's usually one of the most common problems is that people get too aggressive with their bowel program. Then they don't understand why their bowels aren't emptying because they're the ones who's creating trouble for it. So be very gentle to yourself. Is enemy safe for long-term use? It seems to be. I've never heard of a problem with it. So, it's equivalent to a suppository in my mind as far as their actions are different, and some people find it works quicker. The enemies and the suppository has to be placed against the bowel wall to work. So if you just, again, people want to get in and get out quickly, some people just insert the suppository and they insert it right into the stool. It won't melt there. It has to be up against the bowel wall for it to work, all these products. So you have to kind of insert it and then kind of push it over to the side a little bit. Again, not aggressively. You don't want to push it through anything. So with that, I will end the session today, but I thank you for coming. Boy, we cover a lot of topics in this thing, don't we? Well, we go from one thing to another, but it's always interesting. The questions are always very fascinating to me. So remember, if you have any questions, if there's something that piqued your interest or you want to know about, you can go to the Reeve Foundation. There's a blue button on the opening page and it says Ask Nurse Linda. Click that button and you can send me an email and I will answer it. So, or perhaps one of our very smart information specialists might answer it. So just be sure if you have any questions, you can get answers, in the moment, or at least within a very short amount of time. So thank you. And remember, I hope to see you in Phoenix at the Abilities Expo. Thank you for coming.